Welcome, everyone. I'm excited to kick off our presentation today on the mechanics and dynamics of ventilation in respiratory physiology. This slide introduces our main topic, which is an in-depth exploration of lung function, pressure gradients, and respiratory muscle performance. Over the next few slides, we'll delve into how these elements work together to facilitate effective breathing. Let's get started and uncover the fascinating mechanics behind respiratory physiology. Let's talk about the mechanics and dynamics of ventilation in respiratory physiology, focusing on elastic resistance in breathing. Elastic resistance is always present, whether we're breathing dynamically, like during active inhalation and exhalation, or statically, such as when the lungs are at rest. It's a constant factor that influences how easily air can move in and out of the lungs. When we look at resistance to lung inflation, we generally categorize it into two main types. The first is frictional resistance, which only occurs during dynamic conditions, that is, when air is actively flowing. Think of it as the resistance you feel when you breathe in or out quickly. This brings us to the overall mechanics of ventilation. The role of the ventilatory muscles is crucial here. Normally, these muscles can easily overcome these resistances. As a result, the work of breathing remains minimal and sustainable, meaning our bodies can handle it comfortably without undue effort. Understanding these resistances helps us appreciate how efficiently the respiratory system functions under normal conditions, and it sets the stage for understanding what happens when these resistances increase, such as in respiratory diseases. Elastic recoil is a fundamental property observed in both the lungs and the thorax. It plays a crucial role in the mechanics of breathing. Essentially, this mechanism ensures that these structures return to their resting state after being stretched during inhalation. Now let's understand elasticity a bit more. Elasticity is the force that drives an object back to its original shape after stretching. Think of a rubber band. When you stretch it, it pushes back to snap into its normal form. The more elastic the object, the stronger its recoil force when stretched. Focusing on the lungs and thorax, their elastic recoil is what helps us exhale passively. When these structures are expanded during inspiration, their inherent elasticity pulls them back, helping to push air out during expiration. This process is vital for efficient ventilation, and understanding it ties directly into the overall mechanics of how we breathe. Let's start by looking at the mechanics and dynamics of ventilation in respiratory physiology. First, the chest wall naturally tends to move outward or expand. This outward movement is primarily due to the structure of the thoracic bones, which are shaped in a way that favors expansion. Surrounding muscles also play a significant role here. They contribute to this outward movement, especially during breathing. This tendency of the chest wall to expand outward is actually essential for normal breathing mechanics because it helps create the space needed for the lungs to fill with air. Now, turning to the lungs themselves, they have a natural tendency to collapse inward. This inward pull is caused by the elastic properties of lung tissue, which want to return to their resting, smaller state after expansion. So, what happens is that the elastic recoil of the lungs opposes the outward movement of the chest wall. This opposing recoil from the lungs and the outward movement of the chest wall create a balance. This balance is vital because it maintains the negative pressure necessary for air to flow in and out smoothly. In essence, the combined effect of chest wall expansion and lung recoil ensures that our breathing remains efficient and effortless. Now, let's take a closer look at the mechanics and dynamics of ventilation, starting with the elastic and collagen fibers. The lung's elastic recoil force mainly arises from these fibers embedded within the lung tissue, or parenchyma. They serve a crucial role in providing structural support, helping the lung maintain its shape, and importantly, enabling it to return to its resting position after being stretched during inhalation. Next, we have the surface tension forces. These are generated by the thin liquid film lining the alveoli. This surface tension plays a significant role in lung elasticity because it helps keep the alveoli stable and prevents them from collapsing. Essentially, the liquid-air interface creates a force that supports alveolar integrity during the breathing cycle. Now, when considering what primarily drives lung elastic recoil, surface tension actually takes the lead. It contributes the most to the overall elasticity of the lung. This dominance underscores just how vital surface tension is in the mechanics of breathing and overall lung function. Understanding this balance between elastic fibers and surface tension helps us appreciate how our lungs efficiently expand and recoil with each breath. Now, let's take a closer look at the role of pressure gradients in ventilation. Essentially, pressure gradients are the differences between two pressures, and these differences are what drive airflow into and out of the lungs. Think of it as a sort of pressure push that moves air from one area to another. The direction of gas flow always goes from an area of higher pressure to an area of lower pressure. This is a fundamental principle that governs how air moves during each breath. Whether we're inhaling or exhaling, this pressure difference is what causes the air to flow in the right direction. When we talk about pressure gradients in ventilation, it's important to understand that if there's no pressure difference, meaning the gradient is zero, then no airflow occurs. Without that difference, the lungs wouldn't fill or empty properly, which highlights just how critical these pressure differences are for effective breathing. This brings us to how lungs stay inflated. Pressure gradients are key here too, because they help maintain the lung's structure. By creating and sustaining the right pressure differences, the lungs can stay expanded and functional, allowing us to breathe efficiently and comfortably. So, in summary, pressure gradients are fundamental to ventilation. They're what enable air to flow properly and keep our lungs functioning optimally. Understanding this concept is essential for grasping the mechanics of respiratory physiology as a whole. Now, let's take a closer look at some of the key pressure points involved in the process of ventilation. First up is alveolar pressure, or PA. This is the pressure inside the alveoli, which are the tiny air sacs where gas exchange actually happens. The level of alveolar pressure is critical because it directly influences how gases like oxygen and carbon dioxide move between the lungs and the blood. Essentially, the difference in pressure between the alveoli and the surrounding capillaries drives the exchange of gases during each breath. Moving on, we have the airway opening pressure, or POW. This is the pressure right at the entry point of the respiratory system, the mouth and nose. POW is vital because it determines whether air will flow into the lungs. If the pressure at the airway opening is high enough to overcome resistance, airflow begins. So, it's a key player in initiating ventilation, especially during effortful breathing or in certain clinical situations. Next is intrapleural pressure, or PPL. This pressure exists within the pleural cavity, the space between the lungs and the chest wall. What's fascinating about PPL is its role in keeping the lungs expanded. It's normally negative relative to atmospheric pressure, which creates a kind of suction that keeps the lungs from collapsing. Maintaining this negative intrapleural pressure is essential for normal, effortless breathing. Finally, we have body surface pressure, or PBS. This is the pressure exerted on the external surface of the body, essentially the pressure we feel on our chest and back during breathing. PBS interacts with the internal pressures we've discussed, influencing how much the lungs can expand and how air flows in and out. It's a reminder that ventilation isn't just about internal pressures. It's also affected by external factors and the overall mechanics of the body. Putting it all together, these pressure points are interconnected and work in harmony to facilitate effective ventilation. Understanding each one helps us appreciate the delicate balance involved in breathing and how various factors can influence respiratory function. Now, let's take a closer look at the mechanics and dynamics of ventilation in respiratory physiology, starting with the concept of transrespiratory pressure. Transrespiratory pressure, or PRS, is defined as the difference between the alveolar pressure, PA, and the airway opening or mouth pressure, POW. So, in simple terms, PRS equals PA minus POW. This pressure gradient is quite important because it spans the entire respiratory system, covering both the lungs and the chest wall. It's this gradient that drives the process of breathing, allowing air to flow in and out of the lungs. The role of PRS in respiration is essentially as the driving force for gas exchange. Without this pressure difference, airflow would not occur effectively, making it a critical component for proper breathing. When we talk about transrespiratory pressure, it's helpful to remember that it includes the entire pathway from the mouth to the alveoli, encompassing both the lungs and the chest wall. Sometimes you'll hear PRS referred to as transairway pressure. It's the same concept, the pressure difference between the mouth and the alveoli, which facilitates the movement of air. Understanding PRS helps us comprehend how the respiratory system works as a whole, ensuring that ventilation is efficient and effective for oxygen delivery and carbon dioxide removal. Let's delve into the concept of transpulmonary pressure, which is key to understanding how our lungs stay inflated. It is defined simply as PL equals PA minus PPL, where PA is the alveolar pressure and PPL is the pleural pressure. This difference is what keeps the alveoli open and distended, directly influencing their volume. Think of it as the pressure gradient across the alveolar walls. It's what determines how much the alveoli expand or contract. When we talk about the state of no airflow, such as at the end of a breath hold, PL equals the elastic recoil force of the lungs. This shows us that, in equilibrium, internal and external pressures balance out, maintaining the alveoli's shape. The importance of transpulmonary pressure cannot be overstated. It's crucial for keeping the alveoli open and functional, which is essential for effective gas exchange. Without the right transpulmonary pressure, alveoli could collapse, impairing our ability to breathe efficiently. So, understanding this pressure helps us comprehend how the lungs mechanically operate to keep us alive and well. Now, let's discuss the mechanics and dynamics of ventilation, focusing on transthoracic pressure, or PW. This pressure reflects the outward recoil force of the chest wall. Interestingly, we observe this force when airflow is not happening, meaning during rest or pause in breathing. Transthoracic pressure is defined as the difference between pleural pressure, PPL, and body surface pressure, PBS. So mathematically, it's PW equals PPL minus PBS. This essentially tells us about the pressure gradient across the chest wall, which is crucial for understanding how the chest moves during respiration. The strength of this outward recoil force directly impacts the magnitude of transthoracic pressure. The stronger the recoil, the greater the PW. This relationship highlights how vital chest wall mechanics are in the broader context of respiratory physiology. Understanding transthoracic pressure helps us analyze how the chest wall behaves during breathing. It provides valuable insights into the mechanical forces at play, which are essential for a comprehensive understanding of ventilation. This knowledge ties back into the overall theme of how different forces contribute to effective respiration. Now, let's look at how airflow is driven during respiration. The key concept here is transrespiratory pressure, or PRS, which is what actually moves air in and out of the lungs. Think of it as the pressure difference that creates the force necessary for airflow during each breathing cycle. Without this pressure, air wouldn't flow in or out effectively. Next, we have alveolar distension, which is maintained by transpulmonary pressure, or PL. This pressure is crucial because it keeps the alveoli, those tiny air sacs where gas exchange happens, open and ready for oxygen and carbon dioxide transfer. If alveoli collapse, gas exchange becomes inefficient, so maintaining alveolar distension is vital for proper lung function. Finally, let's touch on the relationship between inspiratory and expiratory pressures, especially considering chest wall recoil. Transthoracic pressure, or PW, reflects the forces exerted by the chest wall as it recoils after inhalation. These recoil forces are part of the dynamic interaction of pressures that facilitate ventilation. They play a significant role in the overall mechanics of breathing, ensuring that the process remains smooth and coordinated. Connecting all these points, we see that ventilation relies on a delicate balance of pressures, transrespiratory, transpulmonary, and transthoracic, working together to drive airflow, keep alveoli open, and support the rhythmic recoil of the chest wall. This intricate interplay is fundamental to understanding respiratory physiology. Let's talk about the mechanical coupling of the rib cage and diaphragm. They are physically connected, but interestingly, they can also act independently. This independence provides a lot of flexibility, allowing each to adapt to different breathing scenarios. Now, when we take large volume breaths, especially near maximum lung capacity, the movement of the rib cage becomes the dominant factor. This helps support the lungs and allows us to intake more air when needed. Both the rib cage and diaphragm work together during normal, resting breathing, but their roles can shift depending on the situation. However, certain conditions, like obesity, pregnancy, or abdominal distension, can make breathing more challenging. In these cases, the reliance on the rib cage's movement increases because the diaphragm's motion is restricted. In quiet, restful breathing, the diaphragm takes center stage. Its displacement is the main driver, ensuring efficient ventilation with minimal effort. This dynamic interplay between the rib cage and diaphragm highlights the adaptability of our respiratory mechanics, which is essential for meeting varying oxygen demands throughout different activities and conditions. Now, let's talk about the significance of lung volumes. Understanding these volumes is really key when it comes to assessing how well the lungs are functioning. They give us insight into the basic units of air within the lungs, which helps us evaluate and monitor respiratory health more effectively. Next, we'll look at how the air we breathe is organized into different compartments, which we classify as volumes and capacities. Think of volumes as the fundamental, non-overlapping units of air in the lungs, each representing a specific amount of air. Capacities, on the other hand, are combinations of two or more of these volumes, giving us a broader picture of lung function. Finally, let's consider the role of lung capacities. Since capacities are made up of multiple volumes, they are especially useful because they reflect the overall ability of the lungs to hold and move air. This makes them essential tools for evaluating the general functionality of our respiratory system. Understanding these concepts helps us see the bigger picture in respiratory physiology and how the lungs operate as a whole. Now, let's talk about residual volume, or RV. This is the amount of air that remains in the lungs even after we breathe out as much as possible. It's an important volume because it helps prevent the lungs from collapsing and ensures that gas exchange can continue smoothly between breaths. Next up is expiratory reserve volume, or ERV. This is the extra air you can push out of your lungs after a normal exhalation. Think of it as the additional effort you make to exhale more air than usual, kind of like squeezing out that last bit of air. When we discuss lung volumes, we also have tidal volume, or VT. This is the amount of air you inhale or exhale during everyday, normal breathing. It's fundamental for basic respiratory function and oxygen exchange, keeping your body supplied with the oxygen it needs. And then there's inspiratory reserve volume, or IRV. This is the extra amount of air you can inhale with maximum effort after a normal breath. It shows how much your lungs can stretch to take in more air during deep breaths, which is especially useful during physical activity or deep breathing exercises. Overall, these different volumes, RV, ERV, VT, and IRV, are all interconnected. They give us a detailed picture of lung capacity and function, helping us understand how efficiently our respiratory system works in both resting and active states. Now, let's move on to the key lung capacities, starting with inspiratory capacity, or IC. This is the total volume of air you can inhale after a normal exhalation, and it's calculated by adding the tidal volume, VT, and the inspiratory reserve volume, IRV. Think of it as the maximum amount of air you can take in from a resting point. Next, we have total lung capacity, or TLC. This represents the sum of all lung volumes after a maximal inhalation. In other words, it's the absolute maximum amount of air your lungs can hold. This capacity is crucial because it reflects the full potential of your lung expansion. Moving on to functional residual capacity, or FRC. This is the volume of air remaining in your lungs after a passive, normal exhalation. It's made up of the expiratory reserve volume, ERV, and the residual volume, RV. FRC is important because it indicates the amount of air that stays in your lungs to keep them open and ready for the next breath, even when you're just resting. Finally, let's talk about vital capacity, or VC. This is the largest amount of air you can exhale after a maximum inhalation, combining IRV, VT, and ERV. It essentially measures the maximum volume of air you can expel from your lungs, which is a key indicator of respiratory health and lung strength. Understanding these capacities helps us grasp how efficiently our lungs function and respond to different physiological demands. Let's walk through the overview of spirometry measurement. First, preparing for spirometry involves having the patient breathe through a mouthpiece that's connected to the spirometer. To ensure accurate readings, nose clips are worn to prevent air leaks during the test. This setup helps us get precise measurements of lung function. Next, during the actual measurement, the spirometer records lung volumes as the patient inhales and exhales. These measurements are then captured graphically, which allows us to analyze how the lungs are performing during different phases of breathing. Finally, the recorded data appears as a spirogram, a visual representation of lung volumes over time. This graph is crucial because it allows us to perform a detailed analysis of the patient's lung function, helping us identify any abnormalities or limitations. Overall, this process is fundamental in assessing respiratory health and understanding how well the lungs are working in relation to the overall mechanics and dynamics we've been discussing. Now, let's talk about the measurement of maximum inspiratory and expiratory pressures, or MIP and MEP. The procedure involves the patient inhaling or exhaling with maximum effort against an occluded tube connected to a pressure gauge. This setup is critical because it allows us to accurately assess the strength of the respiratory muscles. It's important to ensure that the nose is blocked and the lips are sealed tightly during the test. This step prevents air leaks, which could otherwise compromise the reliability of the results. The main purpose of measuring MIP and MEP is to evaluate ventilatory muscle strength, which is a key component of overall respiratory function. These measurements give us insight into how well the muscles involved in breathing are performing. Another key point is that the pressures generated during these maneuvers depend on the lung volume at the time of measurement. This highlights the dynamic nature of respiratory muscle strength. It can vary depending on how full or empty the lungs are at the moment of testing. Understanding these factors helps us better interpret the results and assess respiratory health comprehensively. Now, let's look at some key numbers that help us understand respiratory muscle strength. For females, the normal maximum expiratory pressure, or MEP, is approximately 151 centimeters of water. Similarly, their maximum inspiratory pressure, or MIP, is around -92 centimeters of water. On the other hand, males tend to have higher values, with a normal MEP of about 229 centimeters of water and a normal MIP of approximately -126 centimeters of water. These differences are important because they reflect the typical muscle strength in healthy individuals of each sex. It's also crucial to recognize what indicates a severe reduction in inspiratory muscle strength. If the MIP drops below centimeters of water, that suggests significant weakness, which can impact breathing efficiency and overall respiratory function. Understanding these thresholds helps us identify patients who might be at risk or need further assessment. In the context of clinical significance, measuring MIP and MEP provides valuable insights into respiratory muscle performance. These parameters are essential for diagnosing conditions like muscle weakness or neuromuscular disorders, and they help guide treatment strategies. So, in summary, these values serve as important benchmarks for evaluating respiratory health and ensuring proper ventilation mechanics.